you might call it, perinatal death or fetal demise, or intrauterine fetal demise, lots of different terminology, all referring to the end of a pregnancy. And I began by moderating support groups virtually. I was a volunteer with First Aid Time, and then another organization, Sinafayim, which I currently am the clinical consultant for. And we have gathered up groups of women, and there's usually some men hiding in the background. We'll hear them cough, and I'll be like, oh, there's a guy in there somewhere who's also gaining support on the loss of a pregnancy. We were averaging somewhere between 65 and 100 participants in support, and we were in these support groups, and really acknowledging that this was something that we needed to learn a new language. You need to learn the language of loss and grieving, especially when it comes to perinatal death. And so that's where I began my training. Eventually led me to being trained through the MIST Foundation, which is an organization out of Sedona, Arizona, where I lived in Phoenix, and with Dr. Joanne Cacciatore. And Joanne Cacciatore does a training, an intensive on compassionate bereavement. I trained with her, and really I would describe that as a very pivotal moment from a training perspective for me, where my entire view of what grief and death and bereavement could be, looks like, should be, completely flipped on its head, which ultimately meant kind of closing the diagnostic manual and saying, I need to put this down in order to properly be present and really interact with my clients effectively, successfully, really learn the language of this grief work and take it out of the pathology. So it broadened from there, from perinatal death to reproductive psychiatry work, which is the support of people who are coping with all aspects of infertility, hysterectomies, things like that, termination of pregnancies, and then just even broadening beyond that to perinatal mood and anxiety disorders. And that's all under this umbrella of perinatal mental health or maternal mental health. And that is the category that I exclusively work with, all of which you can begin to hear this theme of loss, right? I imagined I'd get pregnant a year after I got married. I was hoping I would have a couple months, just me and my husband, and then I didn't. And 5 years later, I'm still without a child. You can hear the grief theme, right? So that is how I tend to begin to always conceptualize my case work, is through the grief and loss lens.
Wow. So when you talk about grief, and I'm listening to you talk about a couple who's married for 5 years and doesn't yet have a child, assuming that they were trying to have a child, and you consider that grief. So tell me a little bit about what grief means to you and how that is grieving, a process of grieving.
So it's interesting that you bring that up, because there was a huge conversation, and please slow me down. I tend to get faster and faster as I go, and I always get wrecked on evaluations because I spoke too fast and nobody understood what I was saying. So the New Yorker in me tends to come out as I begin to try to get in as much information as possible. So slow me down if you need me to. There is a huge conversation that took place actually during COVID, where everybody was talking about, this is grief that you're feeling when you couldn't go to your grocery store and you couldn't go to Home Goods and you couldn't see your family and you weren't able to attend brisim and shivas and things like that. That's grief. Or the loss of your social structure, that's grief. Or the having to live and work at home, and that's grief. And the bereaved community, like the bereaved parents community in particular, really some of them had a very difficult time with it. And there was quite a loud kind of outcry from that community saying, don't dilute this grief experience, because when you start saying I'm grieving the fact that I can't go to Home Goods, you're disrespecting almost like the death of a child. I don't know that I actually agree with that. I don't see that as a common thread with people who are bereaved parents or grieving parents or people in general. I tend to see it as an understanding of what it means to live in this space of loss. And really, to come back to your original question of how do we kind of look at this process of leaning in, leaning towards as a therapist, one of the things that you will hear across the board with everybody in this population is nobody wants to listen to me anymore. They're tired of me. Every time I bring it up, they're like, oh, still, you're still there, you're still sad. And there's tremendous discomfort in this grief process, in this grief world. And especially when it becomes very intractable, when it digs deep, and that there really isn't a way to silver lining this experience, stealing a word from Brené Brown. And so we recognize that there's this space that's really uncomfortable for people to experience. The grief therapist the person who is able to lean into that discomfort, ultimately that is the beginning and end of the therapeutic process, frankly.
Beautiful. I want to ask you something, Devorah. First, I just want to mention for those of you who just joined, we're joined tonight by Devorah Entin, who's a licensed clinical social worker in Philadelphia, PA. And Devorah is discussing leaning into discomfort, and Devorah is a specialist in perinatal loss. For those of you who'd like to ask questions, please raise your hand on the bottom right of the screen. Sometimes I mistakenly say raise your right hand on the bottom of the screen, but I mean use the raise a hand button on the bottom of the screen and raise your hand, and we'll call on you, and please feel free to ask questions. Devorah doesn't seem very intimidated to answer them. So again, and if you're going to talk about any particular cases that you're engaging with or have engaged with in the past, please remember that this is going to be viewed by hundreds of mental health professionals in our community, and no identifying or disclosing information should be presented. Please keep that in mind. What was I going to ask you now? So let's go back to what you were just saying about the grieving parent feeling, pretty much what you said is that people feel that they are becoming annoying.
Mm-hmm.
Nobody wants to listen to this anymore. At some point, we want to see people move on with their lives. We want to see them function. And I would say, presumably, what people are struggling with is we don't know how to console the person. Okay, let's just talk about the layperson for a minute, and then we'll get to the therapist. We don't know how to console somebody. And when they come again and again, and it's 6 months and then a year, and they're still crying or grieving, they're causing us discomfort as a family and friends, because we feel somewhat responsible to make them feel better, and we can't make them feel better. So now that discomfort is going to cause us to start avoiding them. And I imagine that this kind of process happens to psychotherapists in the course of psychotherapy, whether we're treating a bereaved parent or we're treating anyone who's really, really struggling with long-term pain or trauma, right? So it becomes, and I think this is where we're going with the leaning into the discomfort. Like you said, leaning into the discomfort is the therapy. Okay.
So yeah. So can I go ahead? Go ahead.
Yeah, I wanted to ask you a question on that piece right there.
There's so much there already in the question that I have to address. Go ahead.
All right. Well, let's just. So this is somewhat, somewhat parenthetic. So the question is, just from your experience, how much of these bereaved parents' experience of them becoming undesirable to others is perceptual versus real? Meaning, how much of it is their own depression talking and saying, nobody wants to listen to me anymore, nobody cares about me anymore, versus how much is, what percent is actually true that they're starting to cause people discomfort?
Okay, so can I back it? Like,
Sure.
I've got to back it up. Okay, so
Sure.
first and foremost, I'll start at the end and then come back to the beginning. At the end, I actually think it's very, very accurate. I think their perception of they are experiencing with others in community, in even pastoral spaces sometimes, definitely sometimes in therapeutic environments, hopefully not as much, they do begin to feel very disconnected and kind of isolated out. They say, like, people don't understand me and they expect me to present a certain way. Just think about how quickly we say, oh, so how are you? Okay, good. Like, the expectation is the answer is good, right? The expectation is when I say to you, how are you? The expectation is, I'm good, Baruch Hashem, right? And we don't give any space for saying, I'm terrible, thanks for asking. And there's a fabulous podcast by Nora McInerney called Terrible, Thanks for Asking, where she begins to kind of address that issue of like I'm not okay, and I'm really not okay.
Mm-hmm.
The other thing that I'm going to quickly take issue with is the use of the word depression. Mm-hmm. When somebody says, nobody understands me, I'm so sad, I'm having a very hard time. That's where we want to begin to depathologize the grief process, especially in the therapeutic space. So yeah, our diagnostic manual, 2 weeks, I can diagnose you with depression. 2 weeks, you've lost a child, sorry, you get 2 weeks to grieve, and then I'm going to diagnose you, right? Now, I know it's all for insurance purposes, it's for billing purposes, it's make sure you get your medical care and you just put your short-term disability, but realistically what that does is it labels the patient with this expectation is that there's something wrong with me if I'm still sad about the death of my child after 2 weeks, right? So now back it up to the original comment that you made about like, people just want me to move on. And I think that if you think about, I think that terminology, that use of the word moving on is one of the things that kind of snags people and creates disconnection. The leaning in component of the discomfort, especially for a therapist, but also just as a human being, right, is to be able to say, I am okay with you being this miserable, this sad, this distressed for as long as you need to be and for however long that looks like. And you can be this uncomfortable and this grieving and this distressed. And you also can work with, we can also figure out a way for you to continue to identify functioning. Meaning, it doesn't have to always look like dysfunction. It can be, I grieve that level of intensity, and I also I cook breakfast, and I made lunches for my other children, and I even showered this week. So helping our clients identify, really honoring with full integrity the grief experience for them as a therapist allows them permission to move forward while continuing to hold their grief.
Yes. Absolutely. And again, you know, this process that I see happening is when we give the person permission, what it does is it dissolves the conflict that they're living in, which is, I ought not be this way, I ought not feel this way. And it says, yes, you ought to feel this way, you should be feeling this way, that makes perfect sense. And now you can live because you're not preoccupied with that shame.
Mm-hmm. I once heard a wonderful therapist line. Somebody said, oh, how human of you, right? So when I'm so distressed and I'm so chaotic and I'm so upset and I had a hard time getting out of bed, well, how human of you.
Right.
And I just like, that really takes away some of that guilt and shame and everything. But I think that part of the challenge that we have, and I will kind of shift you a little bit in terms of knowing when we're dealing with perinatal death, like we're dealing with a stillbirth or a miscarriage at any gestation, is that we're also dealing with, I don't have any forum with which to do this grief work that I intensely need to do. And especially when you're working within a frum population, you're working with people who are very regimented, very anticipating ritual and structure. There is no ritual or structure when we're coming to a stillbirth. A baby never came home from the hospital, there still is no Shiva. Even if that baby, typically, even if that baby even stayed in that hospital more than 30 days, there's still no Shiva if that child was never able to live independently off of the machine. So we can be dealing with people who parented the child for 2 to 3 months and never get to sit Shiva. So all of a sudden, I don't have Shiva, I don't have Shleishim, I don't have a yard site, I don't have anything. What do I do with this grief? Maybe Chazal is teaching me that I'm not supposed to be sad. Now, our Chachamim, our Rabbanim have totally guided us otherwise and have said to us, no, you are absolutely allowed and have permission to grieve in however way you want. And what we find that, you know, they're not encouraging us to sit Shiva or to guide people to, you know, to do a mock Shiva, but we are giving them permission to do the grief that they need to do. And that is extremely liberating for people who are in the frum world to say, you mean I'm allowed to do that? It's okay if I feel that way? And for a therapist to be able to say, yes, it's, of course you're able to feel, how human of you to feel that way. And we will guide you in, you know, some culturally appropriate ways to grieve a baby that you never were able to parent at home.
So back to the question of how much of this is perceptual versus real. I mean, I can actually, I can see it being real. I can imagine myself as a friend, family member, you know, dealing with somebody and thinking like, I'm getting really uncomfortable with this kvetching, you know, that they keep coming back with. How, is there a level or a degree that it's only perceptual and people are actually trying to be supportive? Or is, you know, 90% of this real?
So I would say to you that there's going to be a margin, right? There's always going to be a margin of people that come to me with some level of history. So like, it's interesting. I was working with somebody, you know, a number of years ago that I actually think it was a presentation of OCD. She began to like become quite obsessed with the fact that nobody could get her support right. And it really was disrupting all of her relationships. Like she wanted her to be supported this way versus that way. But that's rare. And it actually throws me off. As a therapist, it throws me off because I'm like, wait, that's not the typical kind of interaction that I have with people. I usually am hearing people who really have been marginalized by family and community. I have women who have said to me, multiple women who have said to me, I walk down the street and I see somebody that I know from work and they cross the street so that they wouldn't have to say anything to me because they know that I had a loss and they just don't know what to say, right? We don't know what to say to somebody. But I will say, you know, and I just as a kind of a caveat here is that I will have people who will say, I have 50% probably of the population who after stillbirth who will say, don't you dare say one word to me, just treat me as if nothing happened, just take me back into the office and pretend that nothing happened. And the other 50% is that, how could you not say anything? How could you just pretend that everything is normal and not acknowledge my grief experience or not acknowledge my loss? So, there's
Yeah.
guidelines that we can kind of come up with, but I actually see this
When
as
people
very
are
common.
grieving, when people are in pain, there's nothing you could say to them that's right. If you say Mazel Tov to the older sibling, the older single sibling of the girl who's engaged, then she may feel that you're treating her as a nebuch. If you don't say anything, she may feel because the sensitivity is so raw and so magnified. That's how people are going to experience it.
So yes and no. I don't 100% agree with you.
Mm-hmm.
Probably not even 50%. I would say like I have some percentage of people. So I think that we have responsibilities on both sides.
Mm-hmm.
Meaning, I actually think that the person who's in struggle has the responsibility to some degree to forgive, to be forgiving of nature to those around them because of that perspective of like people. I once heard a beautiful, beautiful perspective from a client. She said to me, actually, this was in a support group, and she said, I just imagine when somebody uses words and they hit me wrong, I take all the words and I jumble them up in my brain and I put them back into my head the way that I need them to be heard. And I thought, what a tzidkah, like there's compassion and rachamim in that perspective, to be able to say she's doing what she can and what she knows how to do in terms of outreach to me, and I am willing to forgive her and to be forgiven. Now, not everybody has that level of kind of compassion and graciousness. I think that's a very grace-oriented way to interact. But I do see that I find that in general, when you're dealing with a fairly healthy-ish person who is grieving, when somebody says, I wish things had been different, I wish the outcome was better, I wish with you, or just, to be fully physically present is the ultimate in leaning into the discomfort, to lean forward, especially some of us that are still on Zoom, that has become a little bit more complicated, a little bit more technique based, to actually be able to lean forward, to put my hands on my chin, to making sure that my eyes are fully on the camera, really conveying my physical presence with the person who is crying, because I can't lean my body forward with them sitting in the chair next to me or across from me.
Devorah, I want to ask you, I have to be honest. Most of this, we spoke about grief in the past, and it seems that we're all grieving. We're all grieving our losses of the past, of how we could have been, how we could have been better, how, circumstances had been different, and what some of our dreams and aspirations were that we didn't attain, those of us who didn't, at least. And we're also grieving the future that could have been, and won't be, and the past that was. And much of psychotherapy in general is looking back at the past and grieving. I'd like to know if you can somehow put into words, and I know this might be difficult to put into words, but can you put into words how on a less verbal level, or on a verbal level, but not the kind of verbal level that's saying, I know it's so hard, or that's terrible, the kind of basic cliche, but how can we make it more experiential and more real, that the client will sense and feel through our interactions with them that we are right there with them? What do we need to refrain from doing? What can we do? And again, these are very just basic clinical skills, but skilled clinical skills, if that makes sense.
Yeah, I mean, I think the first and foremost is to really believe that what they're doing is okay. You got to start there. You got to start with actually believing that the way that person is grieving, and whatever that looks like, is fine. It's okay. And stop trying to correct them in their perception of whatever it is that they're grieving.
So what are some of the don'ts?
So first of all, very basic don't to say I totally understand, right? Or that's normal. I actually don't like using the word normal. I like to I like to say a lot less than I'm saying, much less than I'm saying. Like I'm doing and being fully present and listening. And I think that
what do you see as saying that's totally normal, or I totally understand? What do you see in that you feel sort of diminishes?
You don't understand them. Even if you yourself lost a child, you don't understand. You will never understand what another human being has experienced unless you literally have walked their shoes from the moment they were born. I don't know their family history, their family trauma, their family pain, the baggage, the parenting. I got nothing. I don't know who their family, their community, their husband, spouses, whatever. So that's number one. To normalize it is to almost disregard it. I think it minimizes it. When I say, oh, that's so normal, of course you feel that way. I think they kind of go, but I don't feel normal. This doesn't feel okay to me. This is so painful to me. How could this be normal?
There are times that we want people to not feel pathologized. And clearly what you're saying is that saying that's normal is not hitting the nail on the head.
No.
How can we create a sense of that's acceptable? Okay, if that would be a more appropriate word, that's acceptable, or that makes sense, that's sensible, without saying that's normal. How can we convey that message?
So I want to give you a story. In part of our training, we had a woman who presented her story. She was moving and she lifted up the television. She had an 8-month-old at home and she lifted up the TV to move the TV, and she was it got too heavy and she dropped the TV, and Rahman al the baby had crawled underneath her. She did not see the baby was beneath her. The television dropped on the baby. The baby had catastrophic injuries and died about 4 days later. They took her off of life support. Every therapist she walked into, she'd said, I killed my baby. And every single therapist said to her, no, you didn't. Of course you didn't kill your baby. Why would you say something like that? You didn't kill your baby. Your baby died. A tragic accident. How horrible. I'm so sorry, but you didn't kill your baby. Why would you, how could you believe that, right? And she was very close to suicide. And she went into one last therapist's office, which was Dr. Cacciatore, and she said to the doctor, she said to Joanne, I killed my baby. And Joanne looked at her and said, and what is it like for you to hold that? And that was the beginning of the therapy. And she described how she sunk to the floor and she began to cry, and she cried for over an hour, and Joanne sat with her on the floor and said absolutely nothing. Joanne got down on the floor. She put her whole human physical self next to her. She got out of the chair. She wasn't behind a desk. She wasn't behind a screen. She was physically, fully immersed in the pain of that person. And it was when that person got up off the floor and began to stop crying. That is where, and always with the permission to get back down on the floor as needed, that is where the therapy begins, right? Just as an example, minor technique, how often have you watched a therapy session or experienced a therapy session where the therapist hands the patient a tissue? Here's a tissue box. I would never hand a patient a tissue. What does that convey? It says, I'm not so comfortable with your snot. Like, clean yourself up a little bit, right? Make yourself more comfortable, make yourself more presentable. The tissues are over there. You need to help yourself. But the idea being like, I need to, and it's so interesting to me because the most cultured and the most well-dressed women who will sit with me in my office, who will literally be wiping the tissue box is right there. And the lack of a need to fix themselves, to put on a face, to put on a show, to put on that external presentation of, I'm okay, that is missing when the interaction with the patient is authentic. When the patient knows, I don't need to fix my face. I can literally sit there with snot and tears and my makeup running, and I'm okay. And then when I leave the office, then she'll look at me, she's like, I probably should wipe the mascara, right? And I think that's the authenticity of, I'm okay with your tears. I'm okay with your crying. But you as a therapist need to actually be okay with the level of distress that this person's about to put in front of you.
Well, I think that illustration really hits home for me. You know, I've debated forever handing a tissue or not handing a tissue, and I think my general rule is, if the client's looking for the tissue or is indicating that they're looking for a tissue, then I'll hand the tissue, and if not, I'll just let it be. And I don't think I ever really fully put words to why that was my inclination, but I think you just hit it on the head. I mean, that's
right.
I really appreciate how you said that. Okay, can we take a question? Are you ready for one?
I'm ready.
All right, Henny, you're on.
Hi, Henny.
Professor Entin.
Nice to see you.
No, it's good to see you again. It's such a treat. So I work in a school, and I deal with, I work with kids that are like around 10 years old. And what happens with kids a lot is that they don't really have a vocabulary for how they're feeling. They don't really have like an emotional vocabulary, and we need to work on that. I'm wondering, like, in dealing with a child around that age who's grieving, which I did, who doesn't really have that vocabulary, saying like, how does it feel to hold that? Things like that you have taught me to say. They don't have the words to really say these things.
Correct.
So,
and that's where modalities have to be completely shifting into much more like play-oriented therapy, you know, pictures of faces and pictures of feelings. Actually, Malki Schick put together the most amazing, I have it on my fridge because it just makes me so happy. It's a magnet of all these different faces of feelings, and it's all in Yiddish. And it just like, it's incredible that she, you know, she needs to be able to identify within the population that her clinicians are working with. Here is a cheat sheet of what am I feeling today? What does that feel like? Drawn pictures. It is a lot less verbal the younger the person is. And you will have patients that just in general, as they get older, you will have patients that have a very hard time putting words to it, right? And so sometimes it is about writing it down or drawing a picture or drawing their grief. Can they draw a picture of their grief? What does their grief feel like today? Where is the grief? Do some more somatic work. Where does the grief feel in your body in this moment? What is it moving? Does it change shape? What shape, color, style? Is it loud? Is it quiet? Really kind of learning how to integrate some of those experiences in order to fully be expressive, because it may not exclusively be verbal, especially if their first language is not English, right? So if our language of communication is English, but their language of communication is not English, then I got to be prepared with some alternative modalities or ways of engaging. Thanks,
Thank
Kenny.
you.
Sure.
Okay, Devorah, next question. Could we talk a little bit about the process of grieving for those who, let's say, you know, lost a fetus? How, and you know, I'm sure people are wondering, how severe can the process of grieving be? They never saw the child, they never had the child was, you know, what we would call a hava mina. Are people really grieving so badly when they lose a fetus? And
Okay.
that's sort of a provocation of the question.
Yes, I know. I'll give you more credit than doing it. So first and foremost is like, one of the things I want to be mindful of is also using the terminology that the patient walks in the door with. So if the patient walks in the door and says, my client walks in and says, I lost a fetus, then we lost a fetus. If the person says, I terminated a pregnancy, then it was a pregnancy. If the person says, I lost a baby, it's a baby, even if it was 6 weeks along. And I want us to be aware of, and I think women perhaps understand this more deeply and intrinsically than men do as the ones who are carrying the baby. You know, if I was in a different audience, I'd be calling us birthing persons, but we can, you know, I can call it women for tonight. But the birthing person or the woman is the one who is experiencing kind of from the moment of pregnancy, the moment of a positive pregnancy test. And frankly, for a woman who's going for infertility treatment, it's from the moment of transfer. It's from the moment of, you know, we've got our trigger shots, we've got all this medical procedures. Like her pregnancy is way more than 9 months, right? So she is knowing that she is potentially, the minute she knows there's a positive pregnancy test, she's already dreaming about the baby's name. She's already planning, you know, in some communities, I've got to register her in preschool. I am imagining, you know, which of my mothers and mother-in-laws are going to be annoyed about the name that we're picking, right? There's a whole dynamic that exists. Now, I will say to you that dynamic will shift and change when there's been multiple losses before. So that privilege of knowledge to the future, of dreaming to the future, is almost exclusive to somebody who has never had a loss. For women who've had losses, all of a sudden it's exclusively about this moment in time, and everything future focused is anxiety driven. What if? I can't even imagine a name. I can't even connect to this pregnancy. How could I connect with a pregnancy when every previous pregnancy ended in a loss? I cannot imagine beyond today. So the anxiety is going to be high. And we as therapists will need to manage the intensity of those feelings that are very, very authentic and actually quite reality based, because the worst has happened to her. And so the anticipation of the worst happening again is very, very real. And so, you know, if I said to you, I always use this as an example, like if I had a car accident, Khalila, on the corner that had a really bad outcome and smashed my car, I probably would avoid that corner at all costs, because it would just bring up so many feelings and memories. And if I can go the other direction, I can avoid that corner for the rest of my life. It's not a big deal. Pregnancy, I don't have that privilege, right? Unless somebody else is having my baby for me, which does happen. But if nobody else is having this child for me, then I have no choice but to walk down that corner every single day for 9 months plus, right? And I will say that not only that, the intensity of anxiety doesn't end upon delivery. Even then, what if there's something wrong? What if now the next shoe is going to drop? So I think that, so when we're talking about grieving, we're talking about, instead of the grief of a parent is historical grief, the things that I will miss about that person, stillbirth and perinatal death in general is about anticipatory grief. It's about, and it's the imagination, it's the grieving actually of the future versus the grieving of the past.
How much of that anxiety is based on the person afraid that something bad will happen versus, and again, this is maybe a subtlety or nuance, but versus afraid of the shame of how they'll be perceived by others if something bad happens?
Yeah, no, it's mostly the first part. It really is an authentic fear. Now, if a person has multiple losses, there definitely shame creeps in. Like, but the shame tends to be very body focused. Like, what is wrong with me? I don't hear it as much as what will other people think of me. Where I hear that train of thought is more along the lines of, nobody's going to want to hear about my next loss. Like, I used up all my points with them, right? Like, I've already talked to them about my first loss. I'm not even going to bother telling them about the 8-week miscarriage, only the 27-week pregnancy, 27-week stillbirth. So like, they lose that ability to grieve any aspect of the losses that they're experiencing. So yeah, no, it's primarily that tremendous fear of these pregnancy failures. And I will tell you that as a community, we have seen an extraordinary increase in stillbirth. Either it's because more people are getting help within our Orthodox community, meaning the engagement of people who are experiencing later term losses, they're reaching us, so we're documenting how many people are engaging in service, or we are actually seeing a rise in stillbirth.
Now, just totally off topic for a minute, but in the topic of miscarriages, I just heard anecdotally that over COVID, there were many, many miscarriages. Do you know that to be the case or not?
Yes, that is not anecdotal. We are documenting that. Our perinatal kind of researchers are absolutely seeing that. So I'm gonna put in, whether you like it or not, I'm putting in a plug for vaccination, and here's why. What we know is that pregnant women are at higher risk.
I might have to turn off the recording for this.
I don't care. I'm on record on this one.
Right.
I'm supported by the American College of Obstetrics and Gynecology on this one. ACOG has made a full recommendation, but here's why.
People could care less.
I know.
Go ahead.
Say it anyways. So what we know is that women who are pregnant and get COVID have significantly poorer outcomes. Our ICUs were filled with pregnant women, not everywhere and all the time, but they actually had poorer outcomes. The other thing is that we know that COVID has implications in terms of blood clotting, and the placenta needs blood flow. So we had an increased rates of stillbirth and miscarriage for people who got pregnant and also got COVID. I actually have changed my intake process. So when somebody comes to me post-loss within the last year, I will say to them, were you positive with COVID when you had your loss? And the answer has been not 100%, but about 80% the answer has been yes. Wow. So the risk to a pregnant woman getting COVID is a lot greater than a regular average human being.
Okay. I'm not sure if that means that it makes it more likely that they'll lose the baby. I mean, you're saying that
we're saying that there is a higher risk
percentage
of a poor outcome for a woman who is pregnant and gets COVID. And that is why that is a known risk versus imaginary risk.
In full disclosure, okay, the reason I brought that up was because I know a number of people who had miscarriages over COVID. I don't believe that they had COVID at the time, but they did, they had COVID at some point. And my wife and I had a baby about seven weeks ago, and we both contracted COVID in January, and it was a source of concern, especially hearing so many stories like that. And Baruch Hashem, our baby is doing great.
Baruch Hashem.
Question for you. We'll see if I could bring myself back to that question. It's not coming up. There was a question here in the chat from Racheli, and she wanted to know about husbands or dads.
Yes.
Okay. Can you speak about the grief of fathers when their wives experience miscarriage? I'm curious on how their experience is different than the women and how to support them.
I love that you asked that question. I really do. I think we do want to delve in a little bit more just in terms of grief and what grief looks like in the perinatal loss experience as well. But what you're asking also is that, one of the things that we see most typically is the person who is the identified patient is the female, right? How's your wife? Most people will say, if you heard you had a loss, oh, how's your wife doing? How many men get somebody to say to them, and how are you? You know, I had a woman who was sitting in.
By the way, same thing with postpartum.
100%, 100%.
There's
So I'm going to
dads
give you
out
a
there.
statistic. Let me tell you about a statistic. Yeah,
Yeah,
look at, there was
let's
a big study that was just released a number of years ago, within the last 2 years, pre-COVID, that women have an average, we have a risk of 1 in 5 to 1 in 7 women will develop postpartum depression or anxiety disorder. 1 in 7 is the typical number. 1 in 10 men will also actually develop postpartum depression. Now, the women on the call are kind of go, well, could we at least just have something for ourselves? Like, do we really have to share this platform with the men? But we are acknowledging that it isn't, first of all, we know it's really not exclusively hormonal. We know that a lot of this is about transition and a lot of kind of becoming a parent and the exhaustion that goes along with it and kind of the disruption to people's lives. I feel like this is another conversation. But what we're talking about here in terms of the father. So I will share with you, I had a woman who was sitting in my office with her husband, and it was an intake, and the mother had almost died because of a severe birth complication. The mother was in an ICU, she was comatose, she was bleeding out. It was a very severe trauma. Thank God she lived, the baby did not, okay? So, you know, these are more rare circumstances, but they're not so rare to me because those are the ones that are walking into my office. When they survive them, they walk in my office, or somebody similar to me. And after we did this whole intake with the woman, and I turned to the husband and I said, and what was it like for you to watch your wife in really hovering between life and death? And he immediately burst into tears. And he said to me, nobody has asked me that. You're the first person to ask me. And so all of you that have, you know, trauma experience, we're talking about that vicarious trauma, the observer of trauma can be diagnosed with PTSD. There's no question that this exists in literature, but we forget that the husband is also part of that. So the answer to the question is, he is grieving too. He may grieve differently. Men also have a certain structure that enables them to grieve that enables them to distract from the grieving, right? So in an Orthodox home, the husband's running out to Shachris, Mincha, and Maariv. You know, depending on how busy the household is, he's definitely running for Shachris, Mincha, and Maariv, right? So the husband is leaving into this structured space. He has a chavrusa, he has a yeshiva, he has a job to go to. The woman is kimputern. The woman is healing and recovering it physically. And so the processing of grief looks very different, but I want us to acknowledge that we need to ask him too. Talk to me about your sadness and your grief. But usually the answer that I get, just take care of my wife. If she's okay, I'm okay, right? It comes from a compassionate space, but it also really undermines their own personal intensity and process. And what we'll see it is, sometimes we'll see it explode in the postpartum or in a subsequent pregnancy, where we haven't addressed his anxiety or his sadness or his grief, and he never was given that space or process to do so. I do find that sometimes tefillah can be a meditative place for them to be present with their feelings. Not that they're, you know, crying in their tefillos, but that they actually get to kind of step away from life for a couple of hours, potentially a week, and that could be some of their healing or kind of mindful process of attempted grief. But very, very often, too often, the focus is exclusively on her. So checking in on him, acknowledging his process, knowing and helping the two of them actually communicate what each other's needs are, is incredibly, incredibly crucial.
It makes me wonder, I mean, when you have a couple who has just a fairly healthy marriage, do you see the couple together or do you see the woman individually?
Usually it depends on what they request. I mean, I always invite the husband in, always. It depends on if it's a typical pregnancy loss, early or mid-trimester, they tend to be female-centered, but but if she says, can my husband come with me? The answer is absolutely. And they don't necessarily come consistently, like it's usually not a couples focused issue, but you get so much insight into the dynamic of how they're grieving.
Well, you get insight into the dynamic, but I also wonder how much insight the husband gleans by observing and watching the therapist model.
Yes.
How to lean in to the discomfort, how to sit with the pain, and how to be comfortable with that, and watching his wife come around, going from, even in the microcosm, just in the session, going from grieving to calm, or from hysterical to settling down and relief, and how powerful that could be for a spouse to observe so that they can then incorporate that. I mean, guys aren't so good at this typically, stereotypically at least. Some guys are. Yeah.
But I would suggest it actually goes a different direction as well. What I find most powerful in those sessions is when I encourage the husband to speak and say, talk to me about what it was like for you to go through this loss. And when he's able to verbalize it, it is so connecting for her. It brings her to tears, but it also feels, she walks away and expresses feeling like, I never felt more connected to him than in that moment.
Yes.
Because it's so good for me to hear him being sad.
And he doesn't want to burden, that goes back to what we spoke earlier.
Correct.
He doesn't want to burden her with that. She's going through enough of her own stuff. And when that's encouraged, it again makes her, in a sense, less of a nebuch, less of a taker and a little bit of a giver, which people need to be able to be givers also, even when they're taking. They can't.
It also makes them feel less crazy. Remember, like in that moment, she feels almost crazy for feeling this level of intensity. If he's not experiencing the same thing, like, and she can get very resentful. Like, why isn't he experiencing this the same way I am? So when he's expressive to her, they begin to support each other. And that's much better than the therapist supporting them, is them being able to connect and create communication and a platform for connectivity to the future.
Wow, this is so incredibly powerful. I just want to remind anyone, if anybody wants a comment or question, please raise your hand on the bottom right of the screen, and we'll call on you. Devorah, I'm just finding that there's, just like we started off discussing how there's such a strong connection between perinatal loss and just general grief, which is a lot of what therapy is. I'm starting to just imagine how we can incorporate some of this talk into talk therapy that goes on with individuals who are not struggling with perinatal loss, but in general, how to create that safe place for a husband and wife to be in that context, in the psychotherapeutic office, in which they can become vulnerable with each other, or experience the vulnerability of the other, or the vulnerability of the self in front of the other. How can we bridge this somehow?
I mean, I think in general, that's part of a good therapist, is being able to kind of quiet down the one who's dominating the conversation in order for that kind of supportive conversation to happen between husband and wife. Like, it should be about
but there's something very powerfully emotional about that's sort of being highlighted in this discussion. And in grief, intense emotions are inevitable. In other areas of discussion, maybe anger is inevitable, but other intense emotions are not inevitable, because there's nothing ostensible that's being grieved, right? It's sort of like, I'm upset about this, or she didn't do this, or he didn't do that, or he does this, or she does that, and it doesn't seem like it's a grieving process. I'm grieving the loss of the wife that I thought I would have and didn't turn out to be. I'm grieving the loss of the husband who I thought would accomplish this and that, and he didn't turn out to be. That's also a form of grief. And I wonder how much we can take from this conceptualization that you're presenting, and sort of turn that into classical couples therapy, or therapy, between people in cultivating compassion.
I agree.
Yeah. Do you ever work with non-grieving parents?
I mean, I do a lot of work with the perinatal mood disorders community, right, for the postpartum depression, postpartum anxiety. So, yes.
So, but you never have a teenager who comes in and says, "You're so old-fashioned, you stupid bum log. What are you doing?"
No, so I give them to other people.
How do you ever have fun doing therapy?
That does not float my boat. Give me the hardest, most tragic perinatal loss and birth trauma, and I almost died, and I'm happy. Yeah. But I just say, but I want to respond to that comment. So I want to respond to what I just said. Actually, I'm going to respond to myself. Because it works when you can become comfortable as a therapist with the hardest stuff that walks in the door.
Yeah, absolutely.
And if you're not authentically okay with this, and you'll know when you actually are, versus when other people look at you kind of go, "Oh my God, what did she just say?" Like, oh, I have to be careful actually about my children, because when I'm at my Shabbos table, or if I'm at a kitchen conversation and I'm sharing an experience that I might have had in a therapeutic environment, I'm realizing that I have to be very careful about the trauma that I might be invoking on my kids from the things that I feel as these are normal parts of life's experience.
That's a great point. Great point. Not everybody can handle, just like not everybody can handle blood. If a nurse has no problem with blood, but she can't necessarily spill it all over the
Yep.
place in front of
Yep.
the layperson without having to
Right.
worry that she's now going to have to
Exactly.
revive somebody from
Exactly.
past.
And it's and that's why it's extremely important that if you're dealing with high trauma or high crisis or these kind of situations of death related stuff, you better have your people. You must have your people in your world that you can call, and I encourage you to have people on different time zones, right? So if I'm East Coast, I need to have somebody 3 hours behind me in case I take a phone call at 9 o'clock at night and the whole world collapses for this client, or I am overwhelmed by the intensity of what's been presented to me that I do need to staff it sometimes. It's not common, but I do. Sometimes you get hit with like, it's so not fair sometimes. That tends to be my more pervasive experiences, like, Hashem, really? Like, are you kidding me? That tends to be more of my experiencing, and I need to be able to process that with a therapist who can hold my intensity and the discomfort of that as well.
Yeah, no, we have a question here. I just want to say something. I think one of the most difficult, I'm not practicing very long, I'm doing this about a decade. One of the most difficult experiences that I ever had, and I hate to share this, but was I got a phone call from an individual at 9:30 in the morning, and he was an older man, maybe in his, not older, he was probably in his 60s, mid 60s or something, and he called me up and said, I'd like to talk to you about something. I'd like to come in and schedule a session. I'm not feeling so good, or something to that effect. And I got the message later on in the day, and then it was about 12 hours after I got that message, I was scrolling the internet on one of the local sites, only to find out that his Levaya was scheduled for the next morning. And it was a very traumatic and difficult experience for me. I had a lot of questions and confusions and guilt. And there wasn't really anybody who I was able to reach out and talk about, because the story was so self-revealing. If I'm going to start to say over the story, people are going to know who I'm talking about, because not that many people died that day in the community. And it was a very difficult experience. And I had to, find out through many grapevines how this person died. And it, from what I heard, it was a heart attack, sworn top to bottom. But it, it is. And some of these things that we struggle with when we can't get that support could really leave.
So I'm gonna suggest that there is never a case or a situation that you cannot get support. You should never be in a situation that you cannot get support. Meaning, then you need to find a therapist in California. Then you need to find somebody who is not Jewish.
Yeah.
Then you need to find somebody who is a supervisor, previous professor, and say, I don't have anybody else that I can go to, but I'm going to invoke confidentiality with you. And I think that it is crucial. I mean, we deal with this sometimes, especially with psychiatrists, when they lose a patient to suicide. And it is so deeply isolating. And I remember many, many years ago, a newly minted psychiatrist, literally just started practicing within the last 6 months, lost a patient. And she was a personal friend. And she reached out to me, and I just heard in her, and we connected, and I let her be with me and me be with her as a friend. And then I said, I'm going to find you somebody who you can talk to. And I connected her, like, it was so fast. The network is so vast. And I connected her with somebody else who was a senior clinician who was willing to give her hours of time in free support, and like with the understanding of, I need to know that I can really, because in order for me to be able to be present with somebody else, I need to be fully kind of coping with what it is that's in front of me and in my office. And yeah, you had no choice but to find those support spaces elsewhere.
Yeah, and by the way, one of the beauties of being in the firm community, there's millions of people who are willing to support you for free. Yes. And we are an absolutely incredible community. I've reached out to so many people in difficult situations, whether it was a disgruntled client, whether it was that particular story, whether it was another thing. And I've gotten so much, support with a smile. And and I hope to say, I'd love to say that I've done the same for others as well. And I hope we can all do that and be there for each other.
Agreed.
All right, Chevy, go ahead.
Hi. First, thank you, Moshe, for doing this. I really appreciate it. Thank you, Devorah, for being on today. I'm learning so much. So first a comment and then a question. My brother had a traumatic experience with when his wife gave birth to his first child. He came up to find her unconscious, and there was a couple of days of literally being between life and death, and they both made it. Everything was fine. A couple of years later, they had another baby. And then 2 people in the community suddenly passed away in childbirth. And that's when it hit him that this almost happened. He didn't process it. He reached out to me. He never processed that this was about to happen. So he had to go through the grieving, the shock, and everything a couple of years later. So I just wanted to put it out there how we already know that as therapists, that it doesn't always show up when we expect it to.
Yeah, and can I jump in on that for a minute? Sure. And Devorah, help me with this. But one of the greatest mistakes that I see in certain situations, we've been, in my agency, we were involved in 1 or 2, never suicide situations that happen with teenagers, and in other cases, death of parents. And one of the mistakes that the very caring community makes, I think, is the most common mistake, which is that they throw therapists in right away. And you can't provide therapy to somebody who's not grieving yet. And just because this child lost a brother to suicide or lost a parent to whatever disease doesn't mean that that person needs therapy. It means that they first have to absorb what happened, and that can be a week, it can be a month, it can be 6 months, and it probably isn't a week, right? It's probably sometime a little bit further down the line. So your point is so well taken that the grief process or the shock or the effects happen later, and that's when the person needs the support. Right. I don't know if your brother would have sat down with a therapist then how helpful or effective it would have been for what was to come later.
No,
maybe
everyone's like, oh, he's doing amazing, and like some of us was like, he probably didn't even know, he probably didn't understand that he's not a stupid person.
So Chevy, what this, you're actually highlighting something that we deal with very deeply in the birth trauma community, because what you're describing is a birth trauma. And what tends to happen across the board, nursing, medical, physicians, community, family, oh, she survived, Baruch Hashem, we're all good now. But the outcome was good, right? Yeah, she had a hysterectomy. No, but it's good, Baruch Hashem, she survived. She almost bled out, she almost died, right? Oh, the baby survived, Baruch Hashem. And so what it does is it quiets down and totally disregards the traumatic component of what that person experienced. And they actually feel very unable to engage in the conversation about, I survived, but boy, am I not okay, because the rest of the world is telling them they're okay. And what's really profound is we see this among medical providers as well, just as much as, because they are also witnessing trauma, right? So you have a woman in the delivery room who's hemorrhaging, and they're saying vidoy with her, and they're telling the husband, you need to, go prepare her family, and and miraculously the bleeding begins to stop, and she survives. They had to have an emergency hysterectomy and all that, right? And then, and then the nurse is supposed to go deliver. Oh, mazel tov, congratulations, you had a beautiful new next door, right? And the way that they debrief pretty typically in the unit is to go, you're good, right? You're good, you're good. Okay, we're good. Let's go back on. I'll get a beer after my shift. And we lose the incredible exposure to that kind of trauma on a regular basis. Now, is that trauma as typical? Is a trauma experience as typical in an ICU, where we're dealing with high level of intensity and high cases of kind of poor outcomes? Probably not. But for a perinatal provider, they're not trained in this. The OBs are not trained in this. I gave a grand rounds to a group of OB third-year residents, and about perinatal loss. I said, okay, so how many classes have you learned about perinatal death? And they're like, you're the first one. I'm like, 3 years OB residents, you are the first responders, and nobody's talked to you about that grief process and that bereavement process and taking care of yourself and talking to the woman and talking to her partner and coping with no.
And what about the nurses and the OBs themselves? I mean,
that's what I'm talking about. That's exactly right.
I have a relative, a sister-in-law actually, who's been delivering babies for, I don't know, 20 years. And there was one incident. I mean, she had many such incidents, but there was one incident that was so traumatic. She actually had to take a break, a little leave for a period of time. It was so traumatic.
Correct. Yeah.
And
look,
so,
I was engaged in a conversation in an intervention-ish. Okay, in another state and across the country, okay, doesn't matter where there was a horrific, catastrophic outcome. Mother survived, baby did not, but the OBs had called in. They even had to call in like orthopedics because the baby was so stuck and had died literally inside of the mother. The baby had died in the hands of the whatever. Horrific. Okay. The kind of things that they don't even write about in textbooks because it's so rare that something like this would ever happen. And the hospital did not provide support. the hospital was like, okay, well, yeah, we're going to figure this out. And I had an opportunity to just speak completely off the books with that physician, just because somebody had asked me to. And we talked at home, and I was just, at first you begin to be a little panicky, like, this is big, this is so big. And then the minute you start talking with her, you realize, no, I know this is pain. Pain is pain. Just show up for her, because nobody else can have this conversation of what that was like for her. And yes, our providers are being ignored, completely ignored. Some hospitals better than others, but think about what just went down during COVID, right? Was there ever even a moment of debriefing, a moment of coping, a moment of how we're going to help our COVID first responders coping with what they all witnessed, right? I suspect we're going to have, these people are going to come into our treatment over the next couple of years. We're going to have those people, the providers are going to be our patients. And we have to be prepared to be responsive to the traumas that they witnessed, and the losses that they witnessed, and the grief that they witnessed that never was able to be acknowledged, because I got to go right back on to the next patient who also is probably going to die.
So that's a general problem, not only in the maternity unit of medical. I know a couple of MDs, and one of them shares a lot with me what it meant to him during COVID. And he told me one of his colleagues, a pediatrician, I hope no one knows, whatever, I hope I'm not like divulging any confidential information, but she was so overwhelmed, and then she was positive with COVID, and she killed herself.
Right.
Here in the here, not so far, and it's like, because of the information of the intensity, she was short, like whatever. I don't know what went on in her head, whether she thought. But I've seen it. The medical providers I know are at the brink of. They are our clients.
They're hurting. They are hurting. Yeah.
So, question. Can I ask?
Yes, you may.
So, I primarily right now work with children in schools and their families. So I do parenting, and I had this new client. She wasn't adjusting well, and I did an intake with the parent. The mother came in, and she was telling me about the daughter, and there was no really, it wasn't something so complicated. It was more, she's shy and she doesn't have so many friends. But then I realized there's something there, and then they moved from very far away for complicated family reasons a couple of years ago, and it's really, really hard on the mother, and that's spilling over to the daughter. So I asked, how was it for you to move? And when I asked it, I realized I was probably the only person who asked her that, or at least in a supportive way, because the school was always busy with how it's affecting her daughter, and she burst out crying. I ran for tissues because she was so lost, and she was looking for it. And so that's really the end of the story. My question is, I gave her some psychoeducation, how therapy could help her. She had no clue. She never was exposed to these things. Before she moved, she went for therapy to try to avoid the move in her original country. But she doesn't know how it could help her now. She's like, okay, I don't know anyone. I don't have friends. Like, she was very, she was trying to, she was problem solving oriented in a way like, how could it help me technically? So I told her, I told her, it's going to help you deal with your feelings, explore what you can do. I gave her some psychoeducation, but right now her daughter is my client, and I was wondering if you have any insight on that, because I feel like her daughter doesn't have any organic issues. It's just, she's picking up her mother's sadness. She's doing okay in school. She doesn't have friends because she's not reaching out. So I'm working with her, but I wonder what else I can do, if there is anything else, and what it is.
So it's not my area of particular expertise, but I think just remembering that when the home is in chaos and there are parents that are struggling and are hurting or are scared or are uncomfortable or are isolated, it's going to impact the entire family system. So, helping the mother get some support probably would be the most likely, the best way to help the child as well. And then always working with kids in terms of social skill building and emotional intelligence and interacting with other children, how to make new friends.
That's
very basic.
That's my area of where I work most. I was wondering more in how support, like, I guess it's not your area, as you said, but or anyone could jump in, like what supporting a mother, supporting someone who's not directly the client. That's really my question. How that
you can only support somebody who's willing to be supported, right? Remember that. Like, she's not your client. She's not the one who's coming and booking sessions with her. I think always kind of helping her feel that there's there is hope out there by reaching out and getting help, right? I think that what is relevant to me in this conversation is this idea of like, sometimes people don't think that there's anything that can be done to make them feel better. Right. And the recognition that support and connecting to other human beings who speak the same language, and literally or figuratively, knowing that they are not alone in their struggle because of a move or because of family circumstances or whatever, or missing the country she's from, that helping her feel that there is hope out there ultimately is going to impact her family, right? You can spin it religiously because she's the Akara Sabayas, you have so much power here, so much opportunity to impact change on the family system, but ultimately it's about your role as a therapist is to hand off the resources. Here is your brochures, right. Here are the people to call. I believe in your ability to do so. That would be my response.
Okay, thank you.
Thank you. Sure.
Wow. Anybody want to jump in with a question? Go ahead, Bracha.
Hi. Okay, so I'm just thinking, I have a client who she has been
it's actually like that's actually my perspective is don't try to connect the dots. Like I think we tend to try to do that to create a narrative. We don't need to create a narrative right away. First, I got to get a lot more information. And I actually have to listen to the client's narrative of that story. So when she says to me, I had a really difficult pregnancy and a really difficult birth and difficult postpartum. So first and foremost, again, another way that my intakes are going to change over the next 5 years, at least, is going to say, were you pregnant during COVID? Did you attempt to conceive during COVID? I have women who were mid-cycle that the reproductive endocrinology practices, the infertility practices closed. I mean, they're literally $800 in, and they were like, I'm so sorry, we're closing because of COVID. And there's nothing they could do. So their reproductive story kind of really got halted. So that is part of my intake process to say, what happened to you? And how did COVID impact you? The COVID pandemic, not just the disease, but the pandemic. I had a woman who was 50 years old with her first pregnancy. And right when she was beginning to show, like right when she was approaching that like second trimester, where she was going to finally be that pregnant woman in the office, and COVID happened and she's at home, and I could be 9 months pregnant and you wouldn't know it, right? Because everything's existing from my neck up. So she lost all of that identification as I am a pregnant woman. That's a loss for her. That's a tremendous loss for a woman who worked for 20 years to have her first child, right? So how did COVID impact you? How did pandemic impact you as a pregnant person? Very poor access to care, okay? Limited access to care. So again, my pregnant after loss patients, right? They are finally pregnant again. They are in panic mode. Most physicians who are trauma informed will say, listen, you can come in every week or every 2 weeks, and we're going to do a heartbeat check and until you feel more secure in the pregnancy. So those physicians were no longer doing that, and they actually weren't taking the patients until 12 weeks. So she was possibly holding the intensity of, I'm pregnant, I think I'm pregnant, I just had an HCG level drawn, but I didn't have any other testing, I don't know if there's a heartbeat, so she holds that intensity. They said to her, you can only come in alone. And maybe she was scared, and her husband who stormed in was in the car, right? He will experience the entire pregnancy in the car during COVID. My reproductive patients, my infertility patients, they sent their wives in with their sperm samples, and the men sat in the car. There were lines of cars of men lined up in the parking lots of the infertility clinics there to virtually support their wives, FaceTiming while their wives were having transfers. I mean, this is what our community was coping with, right? So go back in time. Let's go back to when you say, I had a hard pregnancy. How did COVID and pandemic impact you? What was missing for you in that time? What would you have imagined this pregnancy could have been like that it wasn't? And taking away that, but everything was okay in the outcome. That's not her story. That's everybody else's story, right?
Try to figure out where her loss was.
All of it was lost for her. All of this was lost. So listen to it, and don't worry about the titling of it. What happened to you? What was your pregnancy like? What was as anticipated and what didn't go according to plan, right? If she had a C-section, something wasn't right? Baby may have been breached. She may have had strep B positive. Baby might have been in a different position. She may have panicked in pregnancy. They were like, let's just give her a C-section. There's lots of reasons why women have C-sections, right? Depending on when in the process of pandemic they delivered, was whether that husband was even at bedside. I had a woman who was wheeled in for a hysterectomy an anticipated hysterectomy. She had placenta accreta and percreta. And so she knew that she was going to have it was a preterm delivery in order to make sure the baby didn't die. Scheduled cesarean section, which she knew was going to be a long, complicated surgery afterwards. And she said goodbye to her husband in the parking lot. And she profoundly described the trauma of being wheeled into the hospital by a non-Jewish orderly. And she's like, I'm going to have my baby with the non-Jewish orderly. Like, where's my husband? She has to recover from that, right? So don't worry about the narrative. Just listen to the actual story. And if you can identify, maybe as she tells you her entire story holistically, the whole thing, then you begin to put together some of those pieces for her and begin to help her connect the dots. She might connect the dots on her own, right?
Okay.
But really
Thank you
giving
so
her that
much.
space to acknowledge it. Yeah, it's a great question. Good luck.
Anybody else have a question before I pitch my next one? I'd love to hear from you. Okay, so here's a question, maybe somewhat of a tough question, but besides being a perinatal specialist, perinatal law specialist, grief counselor, you're also a general psychotherapist, and there are going to be clients who come in who are who experienced a terrible loss, but may have required a lot of work beforehand. And so their loss or their work, is compounded by some of their earlier onset issues. How effective will you be just listening to their story that relates to, if you see the short-sighted story that relates to their loss, the present, current, ongoing loss now, versus taking into account that there's a whole story, a whole history here that needs to be addressed also?
Okay, so first and foremost is I'm a therapist first, by definition. I'm an LCSW first, right? My clinical training involves an excellent intake going back in time. What are the factors that bring you to the room today, right? So even if I have a woman that has perinatal presentation, so postpartum presentation of depression or anxiety, or let's say she had a stillbirth at this beautiful pregnancy ended in a loss. If she has a history of depression, if she has a diagnosis of bipolar disorder, I can't disregard that in the event, that she had a loss and, we're only focusing on the grief, right? It's going to complicate. That's the more complicated grief that we're looking at because, and I don't like that terminology of diagnosis of complicated grief. All grief is complicated, but it does complicate it if she has a history of depression and anxiety. So first and foremost, if I know she has a history of depression and she's been on medication for 20 years of her life or 10 years of her life, whatever, please stay on the medication, right? We don't want to say, oh, now she's grieving, so she's no longer depressed, because grief and depression look extremely similar. The way that their family history is going to impact the grief experience is what has she experienced in grieving before? What is her frame of grief experiencing? Who has ever taught her how to grieve? Was grief ever allowed? Were emotions expressed? So of course, I bring all of that with me into the room as well. So I always have my clinical hat on, but my interaction with the client is going to be a little bit less pathologizing. So the last thing I'm going to recommend to someone who's walking in post-stillbirth is medication, except under one thing. If they are not sleeping, we need to address sleep.
Yeah.
So I just want to make sure everybody's very clear on that.
Okay.
Grief in general.
I think my question related more to when will you identify that someone who's grieving because of perinatal loss is grieving something more that has something more complicated than that needs to be addressed. In other words, you'll rehash the story, you'll intervene, you'll wait, you'll process, you'll sit, and you'll hear the story.
A long time. I'm going to be very honest with you. It's a long time. It smells different. I can only describe it to you like that. I used to, my original training was in a psychiatric hospital, and I always described it as you need to have a sniff test. The best training you'll ever get is the hardest training that you'll ever have, was the one that you could be like, oh, okay.
You can feel.
You can smell it, okay?
I lost part of my sense of smell in COVID, so I'm not doing well.
You might not be able to smell it.
Yeah.
So I would suggest like this. You begin to sense that there's something that is more historical in nature than just the
So
grief
using
process.
your clinical intuition.
Yes.
We have one or two more questions. Do you think you can take them?
Go ahead.
Or
Yeah.
okay.
10, 20. I'm going to have good boundaries.
Yochanan, you want to jump in? Go ahead.
Hi, thank you.
Yochanan, I just want you to be mindful. There's one other person who has a question. So if we can make them both concise, then we can get them both in. Otherwise, Devorah will hang up and someone else will answer. Go ahead.
Coming to back to your area of expertise, I guess. I do counsel couples that are going through infertility. And so one of the things that you mentioned before is that the husband sometimes going through, let's say, an IVF cycle, and there was a positive result, which wound up like negative a couple of weeks later.
Right.
So like the husband may not even think that's called like anything. And what calls it, I was pregnant. I see the husband's eyes sometimes open. It opens a new door for them, and then the corridors of compassion just come out. That's something you mentioned before. But how would you go to somebody that has, let's say, going through an IVF cycle? They have a bunch of eggs and things prepared. They've been through, let's say, there was a retrieval of 6 or 7. They're down to their last one, and they're sittering. They're totally afraid to do that last one because it could take them another 1.5 years or 2 to collect a good sample. It's all things being right and equal because it's a difficult case. What would be the approach to it?
I think, so much of it is holding the intensity of what they're feeling. Like that they are scared and frightened because what would it mean if it worked? But what would it mean if it didn't work, right? What would it mean if we were successful in this transfer? And what would it mean to feel like this was our last hope, right? That's really ultimately a lot of what we're asking for, is this kind of last hope experience. I would say that a lot of it is being present. So much of what we are doing is about helping people who are intensely kind of in chaos around, when I'm speaking specifically around infertility, and how the world is extremely out of their control. Helping them stay in today, in this moment, based on everything I know, based on everything that's presented in front of me, based on my medical knowledge and what my doctors are saying to me, I am okay today. So I think it's grounding. I think it's planfulness. I think it's grieving all at the same time. I'm frightened and I can also make a plan to do my next transfer. I think it's really being fully appreciative of what they're experiencing is very, very real, because I'm imagining with a complex case, it's going to take them 1 year to get more embryos, then we're probably talking about some kind of malfactor. We're dealing with some kind of complex medical interventions that are going to be necessary, right? So because just to clarify for anybody who doesn't have that experience, is that a typical retrieval could happen over 2 to 3 months typically, right? Typical prep, and it doesn't take that long. You may have to come up with another $25,000, but it doesn't take that long from a physical experience. But really acknowledging the conflict of moving forward versus staying put, right? We worked with somebody, we were in consultation today with somebody also who, like, if I move forward, this was a Catholic woman, and she said, all of a sudden she began to develop these thoughts of, like, I'm going against the church if I go ahead and do this IVF, because the Catholic Church is still opposed to IVF by definition. And so obviously for her, this was more of an OCD presentation than it actually was. It was more of a scrupulosity. So we always want to screen out for some of those things, the obsessive nature that can happen, but kind of helping her tolerate what happens if it works versus what happens if it doesn't.
Okay.
I'd like to, Mr. Chairman, I would like to just put in kind of one plug for education in general, with your permission. I want to clarify one thing. We tend to be like Psychology Today profiles. You tend to like check the box of like, oh yeah, I could treat that. Oh, I could treat that. It is incredibly important to me as a provider that if you are going to treat and you're going to check that box for infertility, or you're going to check the box for postpartum, that your training must include advanced training beyond what you learned in your college and what you learned in your master's program. No matter how fabulous of a program it is, we do not have tracks that train us in perinatal or reproductive psychiatry. By the way, most psychiatric programs don't have a track that teaches reproductive psychiatry. It's a very rare board certification that is growing, but is still pretty limited to go on and do a fellowship in post psychiatry. I'd like to recommend Postpartum Support International. I don't get any benefit from me recommending them. I do some of their trainings, but they really have a very good, basic, comprehensive foundational training in perinatal mood and anxiety disorders. So that's postpartum.net. Take a look at them. Seleni is another one. They are New York based. An excellent and maternal mental health, maternal mental health or maternalmentalhealth.org, I think it is. It's 2020 Mom. They all have like modules in collaboration with Postpartum Support International in training in perinatal mood and anxiety disorders. Infertility is different. You are going to train and treat, if you're going to treat people with infertility, please get training in American Society of Reproductive Medicine in ASRM. American Society of Reproductive Medicine has 18 hours for therapists specifically in mental health care of people who are dealing with infertility. So that's my plug for making sure you are actually
Could you repeat that, please?
American Society of
ASRM.
Reproductive Medicine, ASRM, and they have, basically if you join if you become a member, the first 6 hours are free, and beyond that is not very expensive for another 12 hours to 18 hours total of training for mental health therapists. We have Facebook groups. If you're on Facebook, there's several very, very good groups. And by the way, Postpartum Support International has free peer supervision as well. If you're a member and you wanted to join peers, there's 3 different groups now existing monthly, free peer-to-peer consultation groups for perinatal mood disorders.
Ahuva, could you make the question 10 seconds?
Yeah, it's just a comment. I just found that sometimes that the pain is so deep of grief that sometimes the expression transcends language. And I have found that with a friend of mine who had a scheduled C-section, she didn't know if she would make it or if the baby would make it. She actually did die for a few moments on the operating table, but she was revived. And the grief was really so intense that what she did later on, she is musical. She did compose a song and she invited a lot of friends. And she was able to sing her grief. And I found that they did that in Meron as well. You know, they all gathered together. I had solo members, they got together and they sang together. And it's also very interesting that Rabbi Avram Tversky, he had asked for his children to sing after his kura.
Yes, his own niggin actually. Yes, you find what works for the client. That's really about, the grief work is about making sure that you're connecting with this client needs from you. Sometimes they just need permission to sit and cry. You know, it is so critical that they give them permission to just unravel. And I describe it as a balloon exhale, right? So to be able to, like, when the balloon fills and fills and fills with this intensity of the pain, and nobody wants to hear me anymore, and I don't want to burden anyone with my sorrows, but I can come into therapy and I can just like let it all out. And I know that I will refill that balloon over the next week or two until I see you again. But I give that patient the permission, the client that permission, that I'm okay with that. Let yourself exhale. Be with me. Imo anochi b'tzara. I'd like to end actually with a beautiful story that I had heard, with your permission. A beautiful story that I'd heard. My husband was sitting at the table with Rabbi, I think at the time it was Rabbi Ruvain Feinstein. And Rabbi Feinstein was repeating a story, you know, the classic story, and I repeat this often, the classic story of, you know, the nosy Shamish who was with Rav Moshe, and Rav Moshe was about to go to Mincha, and the Shamish, the knock at the door, and there's an elderly Russian lady, and I'm so sorry, the rabbi I need to speak to the rabbi. No, I'm sorry, the rabbi needs to go to services. No, I need to speak to the rabbi, please, right now. And Rav Moshe, of course, said, okay, come in, I'll sit with you. And the rabbi and Rav Moshe sat with the woman for about 20 minutes, and the Shamish is standing at the door listening, doesn't hear very much. And afterwards, the woman left, thank you, Rabbi, thank you, Rabbi, thank you, Rabbi. And so the nosy Shamish says to him, tell me, Rabbi, Rav Moshe, Rabbi, what was she so distressed about? And Rav Moshe says, I don't know. Rav Moshe, what do you mean? Rabbi, what do you mean? Like, she just was with you for 20 minutes. He says, I don't know. He said, so what did you do that comforted her so much? He said, I sat with her and I cried with her. That's what Rav Moshe did. He sat with her. And sometimes not sometimes, all the time, don't forget the power of fully present with that client, because for many people, it's their only moment in their week where someone is giving them full physical FaceTime, right? Without a cell phone, without interruptions, hopefully, right? Without anybody saying, I'm so sorry, give me a second, I'll come right back, right? The therapeutic experience is presence. And when we are fully present with our clients, that's the work. They get better. They do. They get better.
Absolutely. I want to thank you for joining us tonight and bringing this. This is so profound and incredible. I find myself, you know, walking away with you know, inspiration, but inspiration in the work itself. You know, not the kind of fake inspiration or temporary inspiration. I do want to also announce that next week we are having Ricky Greenwald from Boston, Mirza Shem, join us. And he's going to be discussing trauma and some really, really interesting topics. So we hope to see you then. Again, thank you, Devorah, for joining us. We hope you come back at some point.
My pleasure.
And I hope to stay in touch. And anyone who has any questions for Devorah and does not have her contact information, I'm sure you can probably look her up somehow, but you can certainly reach out to me.
I'll put it in the chat. It's just DevorahEntin.net.com. You can reach me through my website.
It can't be DevorahEntin.com. We got to have, what, is it Gmail?
It's DevorahEntin.com or DEntinLCSW at
Oh,
Gmail. I
that's
actually have a
website.
website.